definitely turn it off, and just in case, and maybe I will turn it on again. That's perfect.
Okay. Well, hello, everyone. I'm Stephen Patterson. I'm the Executive Director of MedVR, a nonprofit medical XR accelerator in Boston. We have, in our commitment to education, we've been running a talk series over the last few years. And I've got some feedback here that I've got to fix. Hold on for a sec. Found it. That should get it. Okay. Hopefully that cleared up the feedback loop. We're streaming on LinkedIn and YouTube Live, and when you start these things, they open up windows and open up your microphone and speaker without telling you. So what I'd like to say is, when I read about this project that we have today, I was really excited because it was an elegant engineering solution to a surgical solution, to a surgical problem, and found it incredibly interesting and worthwhile. What I'd like to do is, in keeping with this, is as quickly as possible to get started with the talk, to give everybody the most amount of time possible. One note is there's a Q&A icon on the bottom of your screen. That's where you enter the question. The chat is for chatting between the panelists and one another, and the attendees and one another's. But if you have a question, please put it in the Q&A. I'm very pleased today that Dr. Jeffrey Jacobson has joined us to moderate. He's the XR lead in immersive design systems at Boston Children's Hospital. He's been a longtime engineer in the field of XR in many capacities. He's been in healthcare for more than half a decade. He also was one of the founders of one of the largest VR groups in the world, which is Boston VR, and has contributed quite a bit to the growth of the technology here in Boston. And I'll just close and say I really appreciate having a domain expert like Jeffrey to moderate, because it brings out the best in our talented speakers. So on that note, I'll turn things over to Jeffrey, and we'll talk a little bit later on.
Yes, thank you, Stephen. Alicia is a postdoctoral researcher. She did this remarkable study using augmented reality for surgical guidance and planning. It also has great value in communicating with the patient and their family of what a potential ear replacement is going to look like. So I'm going to turn it over to her.
Okay, thank you very much for the presentation. Also, thank you very much for having me here. For me, it's such an honor to be part of this community. So if you agree, I may start with my presentation now. Let me first share my screen. I hope you can all see it now. Okay, so my presentation today, it's called Revolutionizing Reconstruction with 3D printing and augmented reality. My presentation is going to be divided into 6 main blocks, starting first by a little bit of personal context. Who am I? Where do I come from? And so on. Then I'll go through the technical context. What is the context of technology and surgical guidance right now? And then I'll start with the clinical context, which is the condition and the disease we want to treat. After that, I will state which is our proposal, the workflow we are proposing it here, together with the results, and finally I will summarize the conclusions. So let's start with the personal context first. So I do come from Spain, that country all across the Atlantic Ocean. And specifically in Spain, I come from Madrid. My university is called Universidad Carlos III de Madrid, University Charles III of Madrid. And I work in the Polytechnical School, specifically in the Department of Bioengineering, which is, this is my university, the one you can see there. My group is called the IGT group, Image Guided Therapy group, and it's supervised by Javier Pascal. And these are all my mates in here. It's called the Image Guided Therapy group because we try to develop image guided therapies using engineering to treat different conditions. And to make sure we clearly target the clinical problem, we work in very close collaborations with hospitals all around Spain. Personally, I work on augmented reality, which is what the talk is going to be about today. But in our group, my colleagues also work a lot in AI and deep learning, and together with with medical images to try to predict and segment and treat uncertainties and so on. I don't want to go deeper into that, but just want to recognize all the work of our collaborators all over the world, not only physicians, but engineers, and so on and so forth. So just to talk a little bit deeper about myself, I did my bachelor's degree in biomedical engineering in this same university. And then I started doing my master's in information health engineering, which basically is AI to apply to health. I presented my PhD thesis last year in biomedical science and technology, where I precisely focused on AR in this IGT context to improve surgical planning and guidance, just like Dr. Jacobson introduced before. So that being said, let me tell you a little bit about this little project, which was part of my thesis, starting by the technical context. So, as you may know, over the last decades, technological advancements have evolved to the extent of becoming an integral component of our daily lives. I'm talking here about leisure, marketing, industry, and so on. And of course, these innovations have also permitted the field of medicine, aiming to enhance the objectivity and effectiveness of medical procedures, and ultimately making them safer and less invasive. In the surgical field, image-guided therapy improves the delivery of therapies to patients with a synergistic blend of medical images, computational sciences, and cutting-edge technologies in a bid to locate, target, monitor, and control surgical interventions. Ultimately, IGT aims to reduce the uncertainty and human errors, and as well as variations among physicians' abilities. Ultimately, a more standardized and precise patient care is provided, improving overall outcomes. So in IGT, the first step would be the acquisition of medical images of any kind, although we specifically focused in this work on CTs because it provides the highest details on bones, which are our main target in here. And from these medical images, we segment the anatomical structures of interest to create 3D models that accurately represent the patient's anatomy. So in turn, we would have a 3D model in our computers that clearly represents the anatomy of our patients, just like a digital twin, to perform a virtual planning of what we want to do in the surgery and make sure that everything would work for this specific patient. Then using computer-assisted design, we can create 3D patient-specific structures that can be then 3D printed to assist during the surgical procedures. So that would be kind of the overall general workflow of IGT. And this IGT precisely ends up in the surgical room. In this case, in this condition, tracking systems have been the most widely utilized devices for surgical navigation because they can provide real-time position and orientation of surgical instruments with respect to the patient. And the good thing about this is that medical professionals can then accurately visualize and pinpoint the surgical aim with remarkable precision. However, these traditional navigation systems typically display the patient information on external screen, which forces them to move their attention away from the patient, which may in turn disrupt their gaze and moreover the intuitiveness, especially among novel users. So in this context, hello, I'm sorry, I don't know if I lose my connection. Can you still hear me?
Yeah,
Yes.
I can hear you.
Okay, great.
But
Then I'll continue.
you
Yeah.
did list the presentation.
Sorry again.
I can't see your presentation.
Your
Great.
slide disappeared.
Oh, sure. Let me share it again.
I think that was a communications problem.
Yeah. Hopefully
It's
you can
back.
see now. Great. So am I good on this slide? May I go for backwards?
Yeah, you're fine.
Okay. Yeah, so as I was saying, augmented reality emerges as a great alternative to these tracking systems because it can overlay the clinical information directly on the patient, enabling the surgeon to focus on the subject and therefore improving the ergonomics. Furthermore, these devices are way more cost effective than conventional navigation systems. And I'm talking here about a difference of thousands and thousands of dollars. And on the other hand, they occupy less space because they just require a headset or a tablet or just these little devices, which are really small compared to all those bulky systems that may go with a set of cameras and tripods and cables and so on. So everything's in here like benefits, right? It's all benefits in here. However, it's none without limitations. And we consider the Achilles heel of AR technology the fact of aligning virtual and real worlds, what we call registration, which is basically whenever I display some virtual element overlaid to my patient, how do I make sure that it is actually properly aligned with the physical bones, in this case, that patient? So we found out a solution to that problem that I'm going to explain. But first, let me introduce you the clinical context, and then I'll explain my solution related to this. So the clinical context would be microtia correction. Microtia is this congenital malformation of the auricle, which means that a baby is born either without ear or with a diminutive ear with intact anatomical structure, but totally useless, such as the one that you can see here. Its incidence varies among different series, but it's estimated to affect approximately 1 in every 7,000 live newborns, roughly. Just to give some statistics, in 90% of the cases, microtia is unilateral, which means that the contralateral side is completely healthy as a regular ear. And the right side is mostly the one affected in 60% of the cases, and it's more frequently in males, accounting for around 65% of the total cases. And finally, although the exact etiology remains unknown, it's believed to have multifactorial origins involving both environmental and genetic factors. So now we are a little bit more in the context of microtia, and we know what it's about. We want to present the case of an 11-year-old girl who presented microtia on the left-hand side. And as you can see here in this picture, the right ear was perfectly formed, while the left ear presented these deformities. And she was a patient treated at Hospital General Universitario Gregorio Marañón, one of our partners. So she came to us, she wanted an ear, and we found out a way to create it for her. To treat these conditions, traditionally, the regrowth techniques have been defined as the gold standard for ear reconstruction. And it consists in several steps. First, we make a small incision here and retrieve a portion of the intercostal cartilage. And then we carefully carve it. I think I lost, oh, here. And then we carefully carve it to create the perfect ear shape. After that, once we have it, we just perform a small incision here in the head and detach the skin from the bone to create what we call a skin socket, and introduce that ear created from a cartilage, that cartilage framework, in the skin socket. Then we sew it back and we create vacuum so that the skin adapts to the ear, creating the appearance of a regular ear that everybody has. Even though this system is very effective and has achieved very positive results, it raises two main concerns. First of all, what is the perfect ear shape? And secondly, what is the right position in the head? How do we make sure that we don't place the ear a little bit tilted or a little bit lower compared to the contralateral side? How do we make sure that it's perfectly symmetrical so that it looks good by eye? So by looking at the state of the art with a quick search, the state of the art for creating a new ear consists on creating a template of the contralateral healthy ear that, as we said, is usually present in most of the cases. You take that radiographic film paper, you put it on the healthy ear, you trace the most important structures, and you use it as a template. You can turn it upside down so that you have the contralateral appearance, and you use it as a template to carve the proper ear. Even though it's a 2D template, it's somehow good for this purpose. And then to place it back in the head, we place it as symmetrically as possible by using some anatomical references, such as, for instance, the external canthus of the eye would go to the root of the hallux, and the commissure of the lip would go to the nasal wing, or the nasal wing would go to the earlobe. So basically, we used, traditionally, these two systems have been used to achieve these two tasks. However, as you may also imagine, these techniques are manual procedures that are therefore highly subjective and depends a lot on the dexterity and experience of our surgeons. So we wanted to make a new proposal based on these new technologies that we presented before, which is augmented reality. In our case, that would be with a tablet. And we will also combine it with 3D printing, which enables us to obtain 3D physical models out of some virtual modeling that we do on the computer. So as I told you before, I work in IGT, so I base all my work on medical images. So the first step that we did here was take a CT of our patient, generate a 3D model, just as I said before, and just by symmetry, replicate the healthy ear on the contralateral side to obtain what we call the ideal plan. Then, with the assistance of plastic and maxillofacial surgeons, we split this ear into the main segments that an ear may have to create 4 different structures. These structures are the helix, the tragus, the endotragus, and the base. They were all 3D printed in biocompatible materials, some specific resins that can be sterilized and brought to the surgical room. Once there, if you recall that we said that we performed a small incision here in the ribs until reaching the cartilage, the first use of these templates was to optimize the amount of cartilage that we are retrieving from the patient. So we put them here in the cartilage and just retrieve the portions that we would need based on these structures. In addition to this, we also created this small mold to mount all the pieces together. And I want to thank here my colleague Alba Gonzalez Alvarez, who was the one in charge of designing and 3D printing all these parts, which were actually very, very useful for creating the final ear. If you let me show you some pictures acquired in the operating room. Here we started by having these 3D printed structures, which are the templates that I presented before. Here is how you optimize the amount of cartilage that you need to retrieve for every piece. And then you use them also to delineate the specific shape that you might need to replicate this template, which is precisely a copy of what you should have, but in cartilage. Once you have them all cut, you will mount them here in this mold and attach them using different stitches and so on to create what we call the cartilage framework. And here in these pictures, you have it right next to the ideal plan of the ear, which is just the virtual plan that you created. We printed it and we have it one next to the other. They're very similar, I believe. And also considering that this one, it's a little bit more smooth, let's say, but it's because it's considering that the skin is over the cartilage. So now if you imagine this with some skin above, the similarities will be high. Okay, so all this is for creating the new ear. What about positioning in the head? For that is where we bring augmented reality into game. So we created an augmented reality application using Unity, and we make it that's suitable for any Android device. Although in this case, we worked with a tablet, a Samsung tablet, for the sake of having a bigger screen. And if you remember the problem that we mentioned before about automatic registration, the Achilles heel of AR, we solved it using what we call augmented reality markers. These are these structures that we design in our computers and we 3D print into colors. And they have these specific patterns with these singularities that our device is going to be able to recognize. So basically, we use Vuforia, which is a pattern recognition software that is able to identify these little singularities. So it doesn't matter where the marker is in the 3D world. We don't care if it's upside down or farther or closer. We just care where is this, that it's very easily identified. And we say, okay, whenever you find this, wherever it is in the world, I want you to project something with respect to that position. And what is something? Where is that? So we used 3D printing again to generate a splint that will fit in the upper teeth of our patient. So again, this was retrieved from the CT. It was created out from its contour, so it would fit in the patient's teeth, just like if it was a puzzle. So to the splint, we attach this little structure in here where the augmented reality marker will go. So the patient just have to bite this splint. And since we know where the splint is going to be with respect to my head and where the marker is going to be with respect to the splint, we know the relative coordinates of all components. So we can say, okay, whenever you detect my marker, project the ear wherever it has to be. And I don't want to show you this just with animations. Let me show it you in a real video recorded before the operating room. So we went to the clinic and tested the application on the patient. And as you can see, the patient is biting the splint and the ear is perfectly aligned in the head. Because as I said, we know all the relative coordinates between the different elements playing in the game. So now we have designed our workflow for creating the ear. We have designed our workflow for to know where to place it in the head. Let's evaluate our solution. And we evaluated in two ways. First, in a simulation scenario, we 3D printed a phantom, which was also generated from the CT. That phantom corresponds to the skull of that patient. Okay. We also had our splint. In this case, it was 3D printed in PLA just to save some money and costs in the procedure, although the one that was actually employed in the surgery was again 3D printed in biocompatible material. Okay, but in this case, it was all aseptic simulation scenario, so the splint was 3D printed in PLA. We also employed our augmented reality marker and a 3D model of the ear, the one I said before. That's, let's say, our ideal ear. And we asked 6 volunteers to use the tablet application to align that physical ear to the virtual one they were seeing on screen. Then, whenever they were ready and they said, okay, that's done, they will affix that physical ear to the skull using modeling plaster in such a way that everything is fixed. And we used an structured light scanner to acquire 3D photographs and generate a 3D model of the whole ensemble, which is the one presented here in green. And then we aligned that 3D model scanned to our ideal plan with the perfect ear in its correct shape. And we analyzed the differences in positioning between both ears. And here, let me show you the differences between the ears placed by each of the users compared to the ideal plan. The reference model here used to define the positive or negative distances. The positive or negative Euclidean distances is the ideal plan with the perfect ear positioning. And slight shifts, positive are represented in red and negative distances are represented in blue. And here you have the same information, but in a box plot in a more friendly manner. In all cases, considering the mean absolute distance was 2.2 millimeters, roughly. And as you can imagine here, there is no statistically significant differences between users or different repetitions. Okay, so overall, the error obtained was 2.2 millimeters. So, given the good results obtained in the simulation scenario, we then moved to the operating room and used our technology to guide the whole procedures. We already saw some pictures of the final appearance of the ear. So here you can see how the procedure was when trying to place the cartilage framework within the skin socket and how it was seen here in the tablet application. The good thing about this is that the surgeons themselves could hold the tablet and easily interact with the applications at all times, thanks to the sterile bag it was inserted on. And as you can see here, the application also contains some buttons and sliders to adjust the visibility of the virtual models according to the surgeon preferences at each time. So after the simulation and after the procedure, and just like in simulation, we used an structured light scan to generate a 3D model of the final result. I'm having some connection issues. Oh, I'm so sorry. My PowerPoint just crashed.
Oh,
Um,
well, we can hear you.
We can hear you and I can still see your,
it's just I'm trying to go to next slide, and apparently my PowerPoint just crashed. I'm so sorry. I'm restarting it again. I hope we don't lose much time in here.
No
no
worries.
worries. No worries. It's not an uncommon issue.
Yeah, okay. Yeah, hopefully. Okay. Yeah, I also lost my timer, so I don't know how much time I have left. But, oh shoot. Sorry about this. Um,
Oh, no worries
Yeah.
about time. We're at 12:33 Eastern time, so there's you have plenty of time to finish.
Okay, good. Yeah, well, we're almost there. Not much time left though. Okay, so if I continue with my presentation, as I was saying, after the procedure and like in the simulation scenario, we used an structured light scan to generate a 3D model of the final result and compare it to the ideal plan to warranty or to better find out which were the differences with respect to the virtual plan, and therefore evaluate how good was our system for these kind of procedures. And if you let me show you here the ideal plan that I showed you before, derived from the CT, and here the 3D model generated from the post-operative scan. We registered them both together, and here you can see the differences between the ideal plan in blue and the real acquisition in red. If we generate a Euclidean distance map, just like before, to assess the differences, we can see different things. First of all, the mean absolute Euclidean distance was again around 2.2 millimeters, which clearly coincides with the results in the simulation scenario, which means that pretty much the results we're getting here are that, with a maximum absolute Euclidean distance or 4.5 millimeters. But I want to make a stop here and note that the surgical ear was scanned and evaluated right after the surgery, when the patient presented a high inflammatory response. In consequence, the ear was enlarged and slightly deformed with respect to the expected future shape. So, and indeed, you can see that enlargement reflected in the prevalence of blue color in the whole image, right? So yeah, we expect actually the final results when everything is cured and better scarf and everything. We expect the results to be actually better for us. But anyhow, if we compare our results obtained in here with the state of the art, let's start by the ear reconstruction part. And we found this paper published in 2016 where they compare 40 patients and they used X-ray templates and patient-specific templates, just like ours, to create new ears and compare them all. And they obtained these results we are getting here. As you can see, patient-specific templates are always going to be better, so this is a support for our project. In our case, the results are closer to the results obtained with the X-ray templates, but if we recall that inflammatory response after surgery, we hope that the final year will have slightly lower numbers anyhow. Regarding the ear positioning, there is another work published in 2020 where they used Microsoft HoloLens 1 to orient the placement of an ear, pretty much like we tried, but they did it with Microsoft HoloLens 1. In their case, they performed this manual registration using 3 different anatomical landmarks that they identified through the HoloLens, and they put 3 anatomical virtual points in different places of the head, and according to that, they would reposition the virtual plan. As you might imagine, this has quite low reproducibility and it's prone to errors. So we hope that our results, which are pretty close in in numbers, are also more reproducible and more objective, thanks to this automatic registration. And also the fact of having this tablet application rather than AR on a headset enable this cooperative decision making that release the load of choosing this on just one surgeon. It's split it over all the surgeons and working in the operation. And I want to make a new incision in here. If you recall the shape of the ear here, you can see that it's in red color, reddish, a little bit reddish in here, and blue otherwise. This is kind of showing an actual rotation. Can you see that? Let's say that the ear is somehow positive distance in this way and negative distance in this way is somehow rotated in this actual view. And this totally makes sense because actually, if I may go back to my original slide, this entire procedure of treating microtia is conducted in 2 subsequent surgeries, and they are spaced approximately 6 months apart. During the first surgery, which is the one that we explored in here, the cartilaginous framework is constructed and placed within the cutaneous pocket. And the result is something like this. You sew the wound back and you make the vacuum, and the whole skin is touching the whole ear to the head. So you don't have any space here, which is what you should have if you touch your ear. So this is what we want, what is solved in the subsequent surgery, where the goal is to reconstruct what we call the retroauricular groove, to give that projection to the ear and give that natural appearance. So since we just evaluated our results in that in that condition where the ear was still stick to the head, we indeed have that actual rotation that is affecting our results, but indeed is not a real error of our system. So that being said, and considering that our results are already as good as the state of the art, but that given all these conditions, we expect them to be lower, we can actually say that we are quite proud of the results we obtained. And also aesthetically, let me show you some pictures acquired of the evolution of the patient with time, starting by the intraoperative results, and then some pictures acquired several days, weeks, and months apart. So unfortunately, we don't have any measurements or recording of 6 months later, because this is just a picture that the surgeon took and sent to us once we had a meeting with the patient, but we could not go there and actually take a new scan to analyze it. So that's something that is still pending to have the final results of the interventions. But at least aesthetically and just by eye, we can see that the patient has an ear. So just to conclude, let's give you some final messages. And it's that, to our knowledge, this was the first time augmented reality and 3D printing were combined to provide guidance during microtia correction procedures. And we were able to leverage the advantages of both technologies and achieve results that at least equal and hopefully surpass the accuracy of previous study. And also it gives the chance to practice before surgery using these 3D models. Also, we were able to evaluate our system technically, both outside and inside the operating room. And given the good results and the easy methodology, we hope we laid foundations for treating any other challenging reconstruction. So we are not restricted to just ears, but hopefully we will spread the utilization of AR and 3D printing to other fields of medicine. Also, I'm happy to say that we were already published our paper some months ago, and this is the reference in case you want to have a look at it and read it carefully to know more details about it. But just the take-home message here would be that AR can be successfully introduced in surgical workflows. Our augmented reality marker could be immediately recognized, the registration was automatic, and the system indeed worked, also in the conditions of a surgical scenario. That the utilization of this technology can also enhance the accuracy and patient outcomes compared to traditional technologies, and indeed had a very well reception by the medical community. So hopefully, as I said before, we hope we establish a baseline for more precise, objective, and collaborative approaches to healthcare. So that would be it. Thank you very much for your attentions. And now if you have any questions, please do not hesitate to ask. I will be glad to answer them. Thank you very much.
Thank you, Alicia. That was excellent. I can tell you're a good visual communicator just from your slides.
Thank you.
I might ask you for templates for my own presentations.
Sure thing.
Excellent. Do we have any? I don't see any questions in the chat or the Q&A. I encourage people to enter your questions. I have one. Because you already have the mouth guard and the tracker, could you put that in the patient's mouth 6 months later and compare the 3D model with the ear after it's done healing, for, okay.
Definitely, yes. We didn't do it because when the surgeon met the patient, we were not there and he didn't have all the splint and the marker and everything. But for sure you can do that. You wouldn't have quantitative results, but it will allow you to have a visual overview of the evolution of the patient. So yeah, you can definitely do that, and that's a very, very good thought. Yeah.
Okay. So when you're creating the ideal plan, you have a 3D model of the patient's head and a model of their skull, and you decide where you want that ear to go. And so it seems there's a certain amount of judgment involved in that.
Well, not really, because you're going to take the ear that it's healthy. You're going to mirror it in the other side of the head, and you just need to make sure that it's touching the head. But
Right.
the height, the rotation, and everything is just symmetrical with
Sure.
respect to this axis. So it's pretty objective, I would say.
Okay. And you place it in relation to features on their face compared to how it is on the other side. That makes a lot of sense. Here's a question from the Q&A. What are the advantages of using ear positioning AR software on a tablet versus a head-mounted display, the HoloLens?
Yeah, that's a good question. I get it a lot. And yeah, I would say that I personally have worked myself with HoloLens for a long time now, but we decided to still use a tablet here for two main reasons. First of all, the price, the cost. We want this solution to be spread all over the world, and we want it to be affordable. And the difference in price between HoloLens and a tablet or a smartphone can be times the cost. So that's a very important point in here. And also, once we know the tablet also works in terms of accuracy, that's already a good reason to go forward with this. And secondly, we embrace the possibility of collaborative decision making. When we are working with HoloLens, only the user that is wearing them is experiencing the virtual, is sensing the virtual models and so on. So all decisions rely on that surgeon. However, if you have your tablet, you can move around, you can talk to your colleague, you can decide together, okay, is this aligned? I feel like this is aligned already, but can you say it aligned too? And they discuss, and it feels more like the community. You know that in a surgical room there is a lot of people, so having everybody engaged in the procedure, it's also always a good thing.
Hmm. I'd like to add a couple of things to that. Um, You can, when you're using a HoloLens or something like it, you can project what the user sees on a screen, but
Sure.
that's not nearly as good for the observers, right? With the iPad, everyone is having the same experience or a very similar experience. They're seeing the AR in relation to the head.
Sure. And yeah.
Oh,
Yeah,
go
and
ahead.
also I'd like to add to that that HoloLens are recording the scene through a camera that is not placed right where the eyes are, but a little bit above.
Right.
So what you are displaying in the external screen, it's a vision that does not align with the vision of the surgeon. So in this case, that you want to align something, if you are not seeing it align in the screen, it doesn't really give you any more information. So that's
That's
also the reason why.
That's very interesting. So, if someone did want to use a head mount, they would have to really look at that. Uh,
Mhm.
let's see, another question. Let's see. This is such great work. I'm not a medical professional, but think the surgical procedure can be even more accurate if an HMD is employed so that the 3D image can be projected to the device to guide the surgeon during the procedure. Sorry, let me rephrase that a little. Um, what if the surgeon wore a head-mounted display so they would have access to the AR throughout the surgery? Would that be better, worse, same?
Well, sorry, so you mean combining multiple head-mounted displays,
No,
or?
just having one for the surgeon.
Yeah, sorry, I lost my connection for a
Oh,
bit
sure.
and I missed the question.
Sorry.
So yeah, could you rephrase it again? I'm sorry.
Oh, sure, yeah. So what if like you're using the iPad for the surgical planning? What if the surgeon wore a head-mounted display so their hands are free, and that would give them access to the AR during the surgery itself?
Yeah, well, the tablets is being used during the surgery itself. It was used to guide the placement of the real ear in that patient.
Okay,
The the only disadvantage is that, as you said, there has to be another surgeon or nurse holding the tablet so
right,
that the surgeon that is placing the ear can see the tablet and he has free the hands. So with a head-mounted display, you would free your hands and so on. But yeah, there are ways to solve the issue of having your hands,
very.
just like I said, and still have the other benefits that we discussed.
I would add one more thing to that. The the advantage of a head mount is that it gives you an actual 3D image, whereas the iPad is 2D, but the side of the head and the ear replacement itself are both relatively flat. So you're not getting that much more advantage, in that way.
Yeah, sure, because you're just controlling up and down and right and left, but the depth, you already get it, is the head. So
Right.
yeah.
Here's a good question. How do you calculate optimal positioning for best sound conduction?
Mm-hmm. So in this case, we rely on that the healthy ear is where it's meant to be. So hopefully, when you go to the contralateral side, it also coincides with the best position in the head. Unfortunately, this patient didn't have external ear, but didn't have internal ear either. So it was a bit more complicated than that. The surgery was performed mainly for aesthetic purposes. So we didn't pay that much attention. But anyway, hopefully, if here this ear is placed here because the sound conduction is best on the contralateral side, right, symmetrically, the best conduction should be there. So we hope it also works for that.
Very good. Let's see, a comment. Thanks for this great presentation. All right. Let's see. And another thumbs up floating. Let me see. So I would add to that the brain is adaptive. So
Sure.
if the shape of your ear changes, or if you get an ear when you didn't have one before, there would be a learning time. But your brain can work with a lot.
Yeah, that's true. Mm-hmm.
Let's see. All right. I think that's all I have.
I can see, sorry, I can see here 2 more questions in the Q&A.
Yeah, I asked those questions already.
Okay.
There were, I'm sorry, I see them now. Excuse me. Were there any absolute deviation measurements collected after post-operative inflammation subsided? If not, would you expect the mean error to decrease as the ear heals?
Yes. Yeah, as I mentioned before, unfortunately, we don't have any more measurements after the surgery. But yeah, we really expect the mean error to decrease as the ear heals, because the errors were mostly related to the size of the ear, which we know it's perfect because it fitted in the molds that we created. So we know the ear cartilage, the cartilage framework, it is of the size, it has the size that it should. If the final ear was enlarged, it was because of the inflammation. So hopefully that error will be solved as the heals. And related to the rotation and positioning in the head, when we give that projection to get this groove, we will also solve the actual rotation. So we definitely expect to have lower errors as when we have this subsequent surgery and when the ear perfectly heals. Yes.
It is interesting that second surgery is an opportunity to fine-tune the positioning. Well, I mean, that's by definition.
Yeah, definitely. Yeah, and if there's any error, you fix it there. Yes. Yeah. Actually, the portion of the cartilage that are left, let's say when you're carving the cartilage, there are some portions that you will not be using. Instead of throwing them away, they will introduce them back within the ribs, and the body will create like a little bag around it, so that in the subsequent surgery you can access it again in case you need to fix something that is not there, or you need something else. You can take it back and use it instead of retrieving some more cartilage and performing a new surgery and get up more. That's very, very interesting. So you can always correct just in case. Hopefully we don't need that, but
that's
you have
great.
a chance.
The last question here, I'm a little uncertain about. Could images be superimposed with imaging?
Yes, I believe they are talking about superimposing the CT slides to the head of the patient. If that's the question, as the application is developed so far, you cannot. But I have to say that I've worked a couple of years ago at Queen's University in Canada, and we together collaborate to create an application similar to what you're just saying. In that case, we connect our HoloLens 2 to 3D Slicer, which is a very powerful software for medical imaging treatment. And we connect these two devices together to receive medical images in real time from 3D Slicer in my headset. And it was a very interesting project that was already also published. It's called Real-Time Integration between Microsoft HoloLens 2 and 3D Slicer, and blah, blah, blah. You can try and find it, and you will see that we are displaying that images. So this is already implemented in HoloLens 2. We didn't implement it yet in Android, but I guess it's just a matter of time. But for that project, we could see that it gives a lot of information to the surgeons to actually display the CT slides in the patient, and also scroll around them to see the different planes and so on. So even though it was not implemented here, it's definitely a chance and could be in the future for future applications. Yeah.
Excellent. Questioner says you understood it and nailed it. And compliments.
So Molly P raised her hand, and I've never done this before, but I'm going to click and let her speak. She should be able to talk now if she's still online.
Sorry, that was a mistake. I was trying to give a thumbs up and a heart to this. It was a great presentation. Thank you.
Oh, well,
Thank you.
Yeah. Okay. Well, I've wanted to do that many times, and because sometimes you see very interesting people who are in our in the audience, and and being able to give them an opportunity in real time would be great. But at any rate, I want to come back to one of the compliments came from Dan Rodewig, who is the Director of Development for Carlisle, Illinois College of Medicine, which is out of the University of Illinois, which is part of a research consortium that includes University of Illinois, both the engineering school and the medical school. And the medical school, in 2017, the board said, let's merge the curriculum from the engineering school and the medical school. And they're just starting to produce doctors based upon that curriculum. But they also work with the University of Michigan and the University of Michigan University Hospital and the University of Maryland. And they do a lot of surgical research. The leadership is surgically oriented, and so I wanted to both point that out because they're a wonderful group of people to work with. They don't take a lot of airtime marketing what they do. You find them through searching for research. So they're a wonderful group. But now I want to thank Dr. Pose for her wonderful talk on this subject. This is great. I did some quick analyses, and there's about 20,000 children born worldwide with microtia. And when you think about that, the most surgical resources are going to be in the large cities, and as the population density decreases, the delivery of care for those children becomes more difficult. It's either you come to the big city and or you might not get the same results. But here is an opportunity based upon low-cost technology where they can get the same results as if they went to a big city. And this is a beautiful thing about the this paper, which is that it's great engineering, and the platform chosen has great reach around the world. So thank you. And Dr. Jacobson, thank you again for joining us and for moderating. Always good to have someone with domain experience on board. and want to thank our audience on Zoom, on LinkedIn Live, and on YouTube Live. And this recording will be up and available in a few weeks, in a week, if you want to share it with anyone. So thank you, and look forward to working with you again. Take care.
Thank you very much.